Yes, I'm Dorothy Hatsukami. Good morning, everyone. I'm truly delighted to have Dr. Elisia Cohen speaking to us today. Dr. Cohen is the director and professor in the Hubbard School of Journalism and Mass Communication at the University of Minnesota. She earned her PhD in communication from the University of Southern California Annenberg School of Communication and Journalism. Now, Dr. Cohen began her career at St. Louis University, where she developed innovative communication strategies to improve cancer prevention and detection behaviors in underserved communities. And this is really a very important topic to our cancer center. She then went on to chair the University of Kentucky Department of Communication and led its Health Communication Research Collaborative. At the University of Kentucky, she continued her research on health, disease, and risk communication, and was funded by the Center for Disease Control, NIH, and private foundations. She's been a recipient of several awards for her research and her leadership. And I've had the fortune and privilege of working with her on a research project led by one of her faculty. So Dr. Cohen, I really, truly thank you for taking the time from your busy schedule to come and speak to us. And we look forward to your presentation. So I'll turn it over to you, Elisia.
Thank you so much. These are always so hard to do when your slides are up and you can't see everyone. I wanted to thank you so much for the invitation to speak with the Cancer Center. In my former position in life in Kentucky, I was a member of the Marquis Cancer Center at the University of Kentucky and worked a lot with the cancer control program there. Really for the past few decades, all of my work has been focused on cancer communication and risk communication strategies, primarily in rural areas most recently, but also in urban context. And at the University of Minnesota, I've been here now, I've just finished my third year, and I am in a mostly administrative position. But part of my work and my role has been to mentor junior scholars and to work with others on large interdisciplinary projects. And I've always done this throughout my career. I got started working on the Center for Excellence in Cancer Communication Research initiative in St. Louis, and was really mentored by Matt Kruder there before I went on to Kentucky and worked with the Prevention Research Center there with Mark Dignan, Nancy Schoenberg, and Rick Crosby in Kentucky. So I've worked with some great people on some really interesting projects, and I'd like to introduce them to you today, as well as definitely offer some time at the end of this talk for you to ask me questions. I also do see myself as someone who can be a connector to others in the Hubbard School of Journalism and Mass Communication with similar or different research interests, and I'll say a little bit more about that in my talk. So fundamentally, my work takes a communication approach to studying cancer. And my work, primarily I think about when we change the way we communicate, we might change society. Not every single problem in our society is linked to a communication problem, but many are, or many can be improved by better or more effective communication. And so when I think about communication, usually I also think about communication infrastructure. My background at the University of Southern California, I was raised in a tradition that took more of a sociological approach to understanding the relationships between communication and communities. And we studied storytelling networks between ethnic media residents and community organizations while I was mentored as part of the Metamorphosis project there. And so in Los Angeles, thinking about the communication action context, we'd often be studying the neighborhoods in which media residents resided, the community organizations that were there telling stories. However, my interest was more rhetorical. It was in how stories might matter. And so my research was interested in, what makes stories memorable actionable, repeatable, now going viral. We didn't have social media when I started my career, but now we do. And so thinking about, does who tell the stories matter? Does asymmetry in the system matter? These are the types of questions from a theoretical perspective I've been very interested in throughout my career. But I've also been interested in how new information, innovations in the cancer control context, how an innovation such as HPV vaccination or even FIT testing for colorectal cancer prevention, for example, how that innovation gets diffused in a population. And according to Diffusion of Innovation Theory, and Everett Rogers was a communication scholar, there are 5 characteristics of an innovation that might be interesting for spreading that information or knowledge throughout a social system. Relative advantage, compatibility, the complexity versus the simplicity of what's known, triability, observability. And when any new innovation is introduced, there will be both innovators and early adopters, people who try it very early, and laggards. And so the challenge from a communication perspective is trying to bring the innovation across the population. And that's a problem we see a lot in cancer prevention and control. From my perspective, when I think about how to develop communication interventions, I often look at communication flow, the flow of how stories are told within a social system, the flow of information within a storytelling network and within a communication action context. And often when I look at how people tell stories or who tells stories or what information is provided, I also see gaps, and these gaps often point to gaps in communication that can lead to poor health outcomes and health disparities. So we see in the cancer prevention and control area often divergence between scientific and lay epistemologies or ways of knowing related to prevention service guidelines. So for example, when the US Preventive Service Task Force changes its guidelines around mammography, sorry about that, or other types of screening, it often might be confusing to the public, or there might be uncertainty. For example, in my own research, communication research, helping people understand these guidelines, when approaching populations in rural areas, it doesn't make sense to people that they need to stop screening at a certain age. The lay epistemology is just, age is just a number. Why stop breast cancer screening? We don't lose them, at a certain age, et cetera. And so we need to better communication between scientists and lay people can help improve scientific understanding, knowledge, and actually behavioral outcomes as well. What we also know is that there are often knowledge, attitude, practice gaps, and that can exacerbate the burden of disease in poor and medically underserved communities. So in the Appalachian, Kentucky communities that I've studied, or even in areas in northern Minnesota or up in the Iron Range here, there's often people follow their doctor's advice or opinions. And so they can take a behavioral practice like vaccination, for example, and have very little knowledge about why they are doing something, but they do it because the person that they trust, their healthcare provider, tells them to do it. Other times, they might not be adopting a practice at all because they might lack knowledge, or they might have a poor attitude toward doing something, or there might be some other barriers. But communication can do a good job in closing knowledge, attitude, and practice gaps. So this is often a focus of my research, trying to figure out where there are differences here. And in my work with Dorothy and others, I've been working with Sherry Katz in our school, and we've been looking at the context of how people are quitting smoking, as well as what they think of new e-cigarette products, et cetera. And there's a lot of knowledge attitude practice gaps that occur here. And there's a changing evidence base. There's changing products out there. And so how these changes differentially affect populations, younger or older populations, populations that are underserved, is always something that I've been interested in. And then the third way that communication flow can matter is that we know that inadequate or even no clinical communication can exacerbate access barriers. And so some of my research in Kentucky, particularly around the issue of colorectal cancer screening, when a referral for a colonoscopy, considered the gold standard, would take 6 to 9 months, and it required someone to take off work and drive a great distance for a colonoscopy. Often there was simply no clinical communication around it. And the reasons why a FIT test wasn't used is because there was often no reimbursement, and so unless someone returned the test. And so if you're a clinician and you're only getting 5% return on a test that costs $7 or $8, I don't know, you might not talk about the FIT test, and you might only, for example, refer people to the gold standard. But that might be inadequate for cancer prevention and control, and it might exacerbate health disparities. So finding out sometimes what is being clinically communicated is very interesting. Often we think that we're providing strong recommendations when in fact what the communication sounds like to a layperson or to an expert like me who might listen to it might be a little bit different. And so we can study clinical communication and improve it to reduce barriers to clinical care and improve health outcomes as well. For me, I'm very interested in designing interventions. Federal agencies are interested in winnable battles. The Centers for Disease Control and Prevention says that that vaccination, for example, is in healthcare services for global immunization is a winnable battle. What's interesting about vaccination is that we have learned that cost alone is not the critical barrier to uptake, and that persuasion is important, as well as provider recommendation for vaccination uptake, which obviously has plenty of clinical implications in the context of a COVID-19 vaccine. We also think that I also choose cancer prevention as a context, although I've worked in plenty of different contexts, because often targeted communication about cancer prevention is all that's needed. That is, there's not a lot of individual variation in what the recommendation needs to be. And so some general, more targeted approaches, but that are specific enough or focused enough on audiences can make a big difference. When I do my work, I always am interested in the context for multi-level interventions. And so here you might be familiar with what is really an ecological model that is used in research. And so often in medical communication, we're intervening with an individual patient. When we kind of spread out through the model, we also might think about other levels in the system that support, so family and social supports, providers and team members, an organization or a clinic-based or practice-based setting, a local community. Obviously, there's a state health policy environment and even a national health policy environment that can make a difference. Excuse me, it's allergy season for me right now. But within these contexts, there's a variety of places that can intervene. I was recently on an NIH panel where I was giving feedback on what constitutes a multi-leveled health communication intervention, and when do we use it, and when is it appropriate? Well, often intervening from this ecological perspective at one point of the system can be effective, but more than one level of intervention generally provides better support and produces better outcomes in terms of health. And so when I look at interventions, often the types of interventions that I'm involved with are not neat experimental designs. They often are complicated. They're built within a community or a practice-based setting, and they really have to be adjusted and tailored. And so a lot of my work is very engaged in the clinical or community setting. So it's a little bit more time consuming than some other types of experimental research. At the same time, the impact can be broader, in my opinion. So when I think about what multi-level interventions I've been interested in and can give you examples of, there's a variety of different ones. But fundamentally, I've been focused on primary prevention with vaccination, screening, testing, and then I've also been consulted with people who have been working on issues surrounding appropriate treatment and care. And generally what that looks like is media campaigns, community or school-based services and programs, providing provider training, technical assistance, helping put together academic and clinical detailing, protocol, for example, patient navigation, and other types of messaging, message testing and design. And I've really had a pretty varied portfolio of experience, and I'll give you a few different examples, but I'd be happy to talk about other ones. So I've started out my career working in interventions and campaigns, and primarily with the Ozioma 1 and 2 studies through the Center for Excellence in Cancer Communication in St. Louis. But I later joined the University of Kentucky, where I was very interested in the Prevention Research Center there's work. We had funding from GlaxoSmithKline, from the Cervical Cancer Free Kentucky movement, and we really created a statewide surveillance project, as well as a very interesting, first of its kind, social media application and media campaign now almost a decade ago, calling Cause the Movement, to really educate Kentuckians and raise awareness about HPV vaccination when it was still very early on in its diffusion. I've also done message testing around e-cigarettes and warning labels with colleagues here. Some of my work has been community and clinic-based education. I'm perhaps most well known for developing the 1-2-3 PAP intervention, which was a research-tested intervention that was designed for 18 to 40-year-old, 39-year-old women at the time, who had not received all 3 doses of the HPV vaccine and also needed to start PAP testing. And I'll talk a little bit about that. Done some work in opioids and opioid prevention and prescribing. I've worked here with and I've just started working with Annie Laurie McCree in our Prevention Research Center at the University of Minnesota. I was part of its renewal application here, and we are doing some focused work in rural clinics around implementing evidence-based practices. And that fundamentally is a communication problem, which is why I've been involved. Some of the projects that I've also been involved with have been on the outreach side, not simply research side and engagement side. So I've developed materials and engagement materials for a colorectal cancer screening intervention in the community that was really designed to improve community conversations around fit testing and diffusion of that service. And recently here, I've been working with our Center for Translational Science on Mika Eder's Science Cafe project, working with urban communities and kind of creating information that's appropriate for the literacy levels and that's adapted appropriately for different communities who are seeking scientific and medical information in Minneapolis. So often my work begins with a common problem, and I thought I'd leave you with some advice along the way of related to, I guess, some findings that are common themes, I would say, across my research. And often someone approaches me with a wicked problem or a tricky problem. And the question usually is something like, why does the standard scientific communication fail? You know, why haven't we implemented this approach, a new approach in our clinic, et cetera? Has there not been uptake? And the answer in my research is often that messages are not matched well to audiences, and they might not be presented in ways that are relevant to them. The other assumption that I might make in my work is that more communication is not better. Better communication is better. And often in public health and in medicine, we hope that based on our scientific expertise and knowledge, that if we just make people more knowledgeable about the problem, that they'll take more preventive actions. However, we know that that knowledge route isn't the only way to achieve behavior change. And in fact, it wears people out. So for example, in the COVID-19 situation, we want people to know how risky COVID-19 is, what a serious disease COVID is, et cetera. And we just hope that if people know this information, they will take protective actions. Yet at the same time, we know from our family and friends that there are plenty of people who are quite knowledgeable, who are not wearing masks, who are not washing their hands, who are not distancing, et cetera. So knowledge-based approaches alone are typically not the focus of my interventions. I often try to look at norms, try to look at practices, and try to figure out what are some better communication practices and defaults to improve scientific communication. And this started very early in my career when I was working on the Ozioma news service. Ozioma means good news. And we basically were looking at ways that mass communication was not always effective, particularly coming from our National Cancer Institute, other scientific institutes put out press releases all the time. And often they miss their mark, particularly 20 years ago or so when I was starting this research. They weren't focused on populations. They weren't targeted to the various different news sources that were in different communities, including ethnic media. And so what we did is we created a news service and we adapted this over the course of time to create better storytelling that would increase the quality and reach of cancer stories, particularly those that were reaching African-American audiences across the country. And so here's an example of a typical news release from NCI that's pretty dry. It's talking about the transdisciplinary research centers and energetics, and it's talking about integrating the study of diet, weight, and physical activities. That press release went nowhere. However, our Ozioma press releases that incorporated some of this information that had a name of a community, specific rates, so it was localized and tailored, along with appropriately contextualized for Thanksgiving, did go somewhere. They were published, and so our goal was to increase the quality of cancer information in newspapers, and also to later in our SEEKR-2 study to work with local agencies, such as the American Cancer Society, to put people in touch so that we'd activate kind of a storytelling network within communities across the country. When we think about the second feature of, I'd say, interventions, or the second tricky problem that my research has addressed over time, is that not all public health and medical problems demand health communication solutions, but many do. So when I moved to Kentucky, I was approached by my colleague, Rick Crosby, who had a problem. And the problem was that he was a public health researcher going into rural clinics and rural college populations. And dose 1 of the HPV vaccine was being given away. And in the rural clinic, 5% of people were getting the first dose of vaccine. At the time, it was only being given to women. So these are numbers of women. very much lower rate. You think that a more educated rural college population would be better. Well, only 6.8% of folks in the rural college clinics were getting the vaccine on the first dose. But the bigger challenge was there was, even when people were given the vaccine for free, and they could come back with a coupon, they could be called back by the clinic. There was no cost to vaccination. Only 4.5% of the population that was coming in was getting 3 doses of the vaccine. This was a failure of the vaccine to penetrate in our rural populations in Kentucky. This was a communication problem that we could solve. And so what we did in our formative research, I often use an engaged elicitation approach where I work with community members to review messages. We did focus groups with young women from Eastern Kentucky, and we tried to figure out what was going on here. We learned that a lot of people's experiential beliefs posed barriers, that there were some complications around the intention, the idea of just getting the first dose is different behavior than getting dose 2 and 3. And this research actually gives me a lot of knowledge around, or a lot of background and insight into the problem of adherence. Getting someone to do something the first time, to get their first mammogram, to get their first pap test, to get a vaccine the first time, is very different than asking them to do something routinely or regularly, because past experience, right, predicts future behavior and experience. And that communication action context looks different the second time than it does the first time. And so that was something that was very important. So we saw in our message development around HPV vaccination that there was a lack of knowledge about HPV. And so even they were getting this vaccination because their health providers told them that it was available today and you should get it done, it's free, so they get a shot. Sometimes they would even be told, it's $180 and you can get it for free today. So comparatively, it looked really great. But they didn't have a lot of knowledge about why they were getting that vaccine. They didn't understand the benefits to all 3 doses, and they were worried that if they didn't get their dose in time, which 18 to 21-year-olds were often not getting their second coming back on time, that they would have to start over. And so they didn't know what to do when they were late. And there were some other obstacles. But there were also some promising message development areas around staying on top of their reproductive health. The idea that this was a new opportunity for their generation. They didn't want to look back and regret it. Some of them had grandparents, grandmothers who had died from cervical cancer. And the knowing that there were some important statistics that were relevant to the population in Eastern Kentucky we were living in. Also, there was something about the 18-year-old, kind of where they were in thinking about their health. Sorry, my slides have a mind of their own. But they would say to us, the vaccine and PAP is really no one's business but their own, and they need to look out for themselves. And they saw it as, a part of them taking care of themselves and taking over their health care. So when they were younger and this was a parental decision to get vaccinated or possibly not get vaccinated, now this was something they could do for themselves. And so we created a video that was a clinic-based video intervention, so that that people would see within a clinic setting would have kind of a standard set of information that they received that was motivating about getting the 3 doses of the vaccine at the point they're getting the first dose. And what was interesting about this intervention is that nearly half of the women randomized to the D completed the 3-dose vaccine series, 43.3%, compared to women in a strong comparison group. And what was the strong comparison group? We had nurse navigators who were reaching out because we really wanted to get everyone a vaccine. And so we did really well, a lot better than the 5% outcomes that you see before. But at the same time, there was a lot of room to move. But what was interesting about this work is that we were also able to test out the dissemination channels. Could it be adapted for other populations in North Carolina and elsewhere statewide? Could we look at the original clinic setting? Would it be better in a waiting room or posted to a website? Could it be modified? And so we evaluated the information for dissemination. And it became part of a research-tested intervention program that was acknowledged by NCI, and with high dissemination capability and high fidelity to the original design. The third point that I want to provide about why communication might be important is because there's plenty of research that suggests that the right message at the right time can save lives. And the wrong message really can prevent health services from being sought out and from being received. And so I can help researchers figure out what the right message is to deliver at the right time. So in the context of outreach for colorectal cancer prevention, here are a couple kind of common things that I heard. So in our rural population in Kentucky, I would hear, I don't have any concerns, but I just don't feel like I need to do it. That's colonoscopy. I've never had one, so I don't feel like I need one. Nothing's wrong. And this is something that we hear a lot, about people not understanding the purpose of preventive service or only going to a healthcare provider if they need one. And this is common in both rural areas in my experience, and as well as in some urban areas, particularly underserved communities. And this is something I would hear from women in St. Louis as well, African-American women in St. Louis. So when we think about what messages we need to be delivering, we need people to understand the benefits of early detection and how it saves lives. Another person would say, well, that's the Roto-Rooter test. I don't like the thought of it. Well, she's the healthcare provider, tried to get me to have it done, and this and that and the other, and I'm bullheaded. So we also know that sometimes providers are not the only sources of message delivery. So in our communities in Eastern Kentucky, we worked with the local American Cancer Society, representatives from our community advisory board, and we learned that family and loved ones could be quite compelling to others to motivate people. So sometimes outreach that reaches people with messages at multiple points. So it's important that a provider make a recommendation and referral, but it's also important that the community, family members, others in their social network can help support that type of behavioral change. My outreach can also help make for more effective message designs. And the question that was raised to me by researchers is, how do we increase demand for colonoscopy and also improve these FIT kit returns? That is, we don't want to give out FIT tests and just let them go out the door and never return. And we also need more people getting colonoscopy so they can have early treatment and screening. And so one of the innovations in public health that was going on at the time was using the FIT to increase demand for colonoscopy. And so one of the things that we knew was not effective message design was focusing, for example, on the brush and the message, et cetera, and trying to come up with kind of ways to explain how to do the test in a way that wasn't yucky, that wouldn't turn people off. And so we found ways to animate how to describe doing the FIT test. We also realized that one of the problems with colonoscopy is the prep, right? And that it takes a long time and people have to take off work, et cetera. So there's a real comparative advantage from a diffusion perspective about FIT tests, but it takes time to explain that to someone. And when a community has never heard of a FIT test before, it's important that people kind of spread the news, that there's a better way of early screening for colorectal cancer prevention. And so what we did, working with local health departments and outreach organizations, is we made an effort to get people in the community to say that they did fit. We had them take pictures. You could use photo voice. There's a lot of different ways to kind of think about this or conceptualize this, to showing that they did fit, and as these kind of pro-social models in their community. You can see the logo that we came up with for the project that featured the mountains in the rural area. And fit, the nice thing about fit is it's kind of, makes you think of something that's healthy, something that's kind of that you're fit or kind of in shape for. So we worked with people to disseminate fit testing through health departments to make it easy for them to pick up and return the tests. And then we had improved navigation to improve demand for colonoscopy. Similarly, when I've worked statewide around HPV vaccination, we've used posters, social media, etc. And here's one example. One of the projects that I had was just thinking about how do we encourage people to kind of share that there is a new vaccine and that this is, a good thing, a good innovation. And so what came out in our message testing as well, of course, we'd want to let people know. And if there was a vaccine for breast cancer, as everyone knows, has extremely high awareness around the issue of mammograms and prevention. There's strong ceiling effects there. So what if we could do that around cervical cancer awareness? And so we created a video, and I'll show you this just with a little bit of animation.
What if a vaccine existed for breast cancer? That's the kind of life-changing news that would start a movement that would spread through your whole social network. Well, HPV, the virus that causes cervical cancer, is preventable, yet millions are unaware. Don't let someone you love stay at risk for cervical cancer. Spread the word and cause the movement for a cervical cancer-free Kentucky. Visit causethemovement.org to find out how.
And so by partnering with others and by kind of having a clear key to action in the message at the time, of course, we were focused on cervical cancer. Over time, messages changed. Whoops. And so we've taken the same approach, or I've taken the same approach to my work that with other work around vaccination. So when the HPV vaccine has been approved for boys and girls, and when we're thinking about adolescent vaccination, we see gaps in some of our medically underserved communities. And so I was working in Eastern Kentucky trying to figure out what would be relevant, compatible with people's values, promote relative advantage, have a simple message, something that's observable and memorable. And I thought I'd share this little clip with you today. The video isn't so much as important as I think the messages. And if you think about what our challenges will be around COVID vaccine diffusion and other types of personalized medicines and or even targeted therapies in the future, this is really an approach that we'll need to take. Oops. Let me go back to this little video.
The flu vaccine is safe and approved for kids as young as 6 months old.
We live in such small communities. Everyone's together, church, schools. My son comes home with the flu. Well, next thing you know, my wife has the flu. And I'm sitting there having to miss work, trying to treat the two that has the flu. It doesn't take long for it to channel all the way around the whole community. You can eliminate a lot of the illness by just taking the vaccination.
I think if parents knew how many children died every year from influenza, they might think twice about not getting it.
Think about it. We tell teenagers to use safety belts in cars, helmets when they ride bikes and ATVs, and padding when they play sports. Flu and HPV and other vaccines are another great way to protect our children. Why wouldn't we take advantage of those?
When I play football, I have to put on all the gear such as helmets, padding, pants, a cup, and cleats. Yeah, getting vaccinated is just like putting on all the football gear.
As they're coming into their teenage years, we're not going to always be there with them.
Parents are given the responsibility of caring for their children, and as such, they need to make good decisions for their children while they have them in their care and custody. And I think that it is imperative that parents do vaccinate their children as one of those good decisions.
Imagine losing your child to, to a disease or an illness. That has to be devastating on a parent. I feel like, I don't want to look back in the past and think maybe I could have done something. And that's one reason I choose to vaccinate my child.
So the reason why this type of messaging is so important is that often researchers or people's first gut about what might work isn't necessarily the right choice. So sorry, my slides I'm gonna have to just pause this. Hopefully that will, I think there's some sort of timing that's on it. Anyway, I will, but when, and so the example that I would give in the context of HPV vaccination is that when people were first trying to figure out how to get boys to vaccinate for HPV, which we know now has benefits for head, neck, other types of oral cancers, et cetera, the message and the instinct was, well, what if we it's about, they'll be a good partner by getting the vaccine. And just to be very honest, the last thing that parents of adolescents want to think about their kid is a future partner to others. And so the message of the work that we did to figure out how to contextualize this within the context of other choices parents made for their children during adolescence was very important. We needed to understand the lay ways of knowing here, which is a principle of development for vaccination. My slide just does not want to stay in the right spot. And one of the things we know was that the other point here is that more isn't necessarily better, but better information can be better for people in all of these contexts. Another principle in my work is thinking about the behavior and audience-specific message quality approaches are important to motivation. We need to figure out in any given population what's personally relevant and engaging. How can that improve attention to a message or to an advertisement? The strategies to promote adoption of a new behavior is different than adherence. And typically my work focuses on addressing those kind of 5 factors for innovation diffusion, particularly in cancer prevention contexts. Often I'm giving advice on how to match audiences, messages, and channels. I had one colleague who really wanted to do something on social media around colorectal cancer prevention for older adult men. However, there wasn't a lot of evidence, particularly in our particular population that had been more rural at the time, that people were engaging in social media for that purpose, particularly those older males. So there was a lot of grandmothers that were getting on social media to see the kids of their see pictures of grandchildren, but not necessarily for cancer prevention. So we really had to think about what are some other routes within a community where we could get those messages together, workplaces, bowling leagues, through other spaces where we could get sex-specific cancer prevention messages out, for example. So matching messages, audiences, and channels sounds intuitive, but sometimes it really requires studying the audience more specifically. I also would be remiss if I didn't talk about some of the other researchers that are doing this type of work. So all of us do work in different levels and study different communication problem. I'm a interventionist, I'd say, at heart, but we have colleagues in our School of Public Health, Sarah Gallus, who does a lot of work around communication and policy. Jisoo Ha is my colleague in advertising, who has a long history of studying direct-to-consumer advertisements from healthcare and pharmaceutical companies. Sherry Katz is my junior colleague, who is working on understanding how people process warning labels and messages, particularly around e-cigarettes and different types of devices or different new products around that deliver nicotine, risky products and harm reduction communication. Rebecca Nagler studies uncertainty in large population studies, does large population studies of media and public opinion as it relates to health communication, and has worked with a lot of people I know in the center here. We have a new faculty member named Adam Saffer, who studies social networks and takes a network analysis approach. His primary area is in public relations, but he also studies message strategy. Emily Vraga is a recent hire who studies health misinformation. She's one of the leading experts in the country on how to correct misinformation on social media, particularly in health and political contexts. And Marco Iser, who's my colleague who has a background in psychology and in health behavior change, and has done a lot of work in different populations in Minnesota and has been here for a while. So that's an introduction to the folks in my college and my school. Email address up here. I'm going to stop sharing so that I can take questions from you. And I think that we should have some time remaining.
Yep, thank you, Dr. Cohen. That was a real fabulous presentation, just to let us know what your background is, but also the potential resources for our people with whom we can collaborate. So really appreciate that information. I guess I'm going to start off. You know, I think you described some of the complexity in terms of effective communication, that it is a multi-level approach. My question to you is, how do you sustain, you know, the communication, and so that people do continue to engage in cancer prevention behaviors?
I think that's a really good question. I think that's why most of my research has been very community engaged, with a focus on that sustainability and thinking about systems change. So a lot of times, and this is true with my work with Annie Laurie McCree that we're just starting with the Prevention Research Center here, when you're trying to get a clinic to adopt a new practice or to think about a different communication strategy, it works best if there are stakeholders that are involved, that are interested in creating this as kind of the operational default and that see some benefit in it. So, so sometimes some messages are one-offs, right? Some campaigns that are bought and earned. But some things, changes that can operate at the policy level, system level, or, you know, just help people find a new way of communicating about a common problem that they have to do every day. So, for example, in the context of vaccine communication in offices, there's good research now about the way that a clinician should be giving a strong recommendation. Interestingly enough, it doesn't take a lot of time. More information and details for parents isn't better. And so there are some just brief scripts that are recommended that if adopted within a clinical practice saves time, will be more effective, leads ultimately to the goal, which is to vaccinate, for kids to be vaccinated, et cetera. So it's trying to figure out what works well in the clinic flow, in the clinical context, in the community context. That work might need to be sustained by an outside organization. It also is the type of work that does take time and relationships built up over time. It took a long time for us to get the relationships in place and the organizational structure and even policy in place to allow us to put, for example, fit kits in health departments in Kentucky, because we needed to make sure that once a positive fit, for example, returned, that wouldn't require, that people would still be able to have a preventive colonoscopy, as opposed to, needing immediately their colonoscopy would result in a large copay, for example. So there were some structural issues that had to be solved along the way before it was ripe for communication intervention. I hope that answered your question.
Yeah, absolutely. Nick, I'm not really sure how to figure out who has raised their hand.
Yeah, Dr. Yee has raised his hand, and I've given him permission to unmute it.
Right.
Hi, Nick. I hope you're just not putting me first all the time, but I always have questions. That was a fabulous talk. And I want to ask a question sort of the opposite direction. I'm a medical oncologist. I see breast cancer patients, and more often than not, people will come in with beliefs that are just not true. And I think this extends into the kind of the larger society. There are people out there in the world who believe things that do not have any basis in fact. So do you have any insight on how that works and how can we use that? And I'm thinking, just give you one, underwire, wires and bras cause breast cancer. So somebody believes that to be true. How did they get there, and what can we learn from why they believe that in our messaging?
Yeah, well, I think that trying to, there's a whole area of people who believe in conspiracy theories and different types of things like that are strongly. So one of the questions that we have to figure out is how strongly is that belief held? How deeply committed to it are they? That is it founded in our religious beliefs? Is it found, And one of the things that I've found, and that you might find in your practice too, although it takes some time to unwind, is that sometimes people hear about these things and get them in their head, but they're not deeply committed to the idea. And so sometimes just asking people, I've been studying cancer for a long time, how deeply, where did that idea come from? Or, how do you know that's true? When I hear you say that, it makes me think X, Y, and Z. And then, is that true? It makes, it can help unravel it. My colleague, Emily Braga, studies this and directly. So she has more insights, I'm sure, based on her work into it. It's how do you correct misinformation? I will say that the research shows, particularly if they're in your office paying for your expertise at the time, that getting corrected by an expert makes a huge difference for people particularly those whose beliefs are deeply held. So I would say my first piece of advice based on the literature that I'm aware of is don't give up. And then sometimes just really help kind of unraveling some of those beliefs. Sometimes when people don't have explanations that they can understand, they come up with ones that are knowable to them. So they might, in the case of that, no one likes their underwear or bras that are women that I know about. I mean, it's not a fun, it's so, blaming that, and that piece of, might, is a piece of kind of everyday way of knowing an experience that they now blame, this new awful thing that they've come to know breast cancer for. It's an interesting problem. I think ultimately the question though is not all beliefs need to be corrected if people just do the right things. So on the flip side of that, people don't necessarily need to know what caused their health problem in order to take action that could save their lives or that could do good things. So sometimes we think that they just need to, know this, but maybe it doesn't matter if that person was getting regular mammograms and is willing to treat the cancer and, really cares deeply about being around 10 years from now to take care of their kids or grandkids or something like that. So not everyone wants to be a scientist, fortunately for those who are.
So Elisia, if there were some cancer center members that wanted to collaborate with people in your on your faculty, what is the best way to go about trying to do that? Is it to contact you, or
Yeah, so the best way is just to reach out to me. I think often people will just, reach out with, typically the way it works is that, people send me an abstract of an idea or, or a problem and ask me if I have a few minutes to talk about it, or if I know someone else on our faculty would be interested in speaking about it. And usually there is, depending on what the context for the problem is, or what people's level of interest and engagement. If someone knows that they, or they have a dissemination project, or they need to, design some materials, that's a specific ask. If they're that some people do have expertise in, if it's more, some people, like I said, have more expertise in public opinion and in a large scale media. Other people do their work in schools or do it in clinics. So I think it really depends on the setting and what people are interested in.
If there's no further questions, then I guess thanks everyone for joining us, and we'll see you next week.
Yeah, and thank you, Dr. Cohen. Really appreciate your time.
Thank you. I appreciate it. Have a great Tuesday.
Yeah.
Thanks so much.
I'm in between.
Thanks, everyone.
Yeah. Bye.
Bye-bye.